there have been quite a lot of advance in the assessment of non-motor symptoms, as we've just talked about, the MDS-NMS being a recent addition, and non-motor fluctuation, which again in clinical practice people were perhaps not giving as much attention to as they do to motor fluctuation. There have been advances in terms of treatment focusing on the non-motor symptoms of Parkinson, both dopaminergic treatment and non-dopaminergic treatment. And these will be coming out in a recent review of the evidence-based committee of the Movement Disorder Society, who are currently updating the 2019 version of the non-motor symptoms treatment for Parkinson's. So there will be updates on the new development in treatment, for instance, of postural orthostatic hypotension, urinary dysfunction, sleep dysfunction, apathy, depression, as well as anxiety management. But there's still a lot of unmet needs, many areas that needs more treatment trials, such as fatigue, such as sexual dysfunction, such as urinary dysfunction. So there's been some development there. We're also very excited that some of the newer advanced therapies, as well as enzyme inhibition therapy, to name, for instance, Opicapone, is looking at the effectiveness of this drug in control of pain in the OCEAN trial. There's a STEM PD trial, which is a vestibular headphone-worn caloric stimulation device, which is looking at non-motor symptoms improvement and this primary outcome measure. Sulfonamide is also looking at pain in its outcome measure. And there are many other trials going on also, for instance, using device-aided therapies, an example being the subcutaneous Levodopa formulation, which is looking at its effect on some non-motor symptoms. Recent data, for instance, presented at this Congress, indicates efficacy of the subcutaneous Levodopa on nocturia. It improves nighttime urination and also sleep. So there are some exciting developments in these areas. There's also more recent literature looking at specific efficacy of deep brain stimulation, using focus stimulation and its effect on either specific non-motor symptoms, such as pain, such as sleep, or the overall non-motor symptoms burden. So there is those advances from the treatment side. We are waiting to see whether the antibody-related treatments and the gene therapies can have an effect on the non-motor symptoms as well, but that data is still not there. And then also, perhaps one of the bigger advance might have been the establishment of the non-motor subtypes within Parkinson. Very recently, there have been two major papers looking at the noradrenergic subtype of Parkinson, which has a collection of symptoms very different to the sleep subtype, which has a different collection of symptoms. And emerging is the cholinergic subtype, where patients have more cognitive impairment, for instance, and you've got to be really careful about anticholinergic use in these patients. The important role of the subtypes is first to enrich the population for clinical trials. So if you're using a dopamine agonist clinical trial, for instance, you would probably want to exclude the PARC sleep subtype because these patients are very sensitive to dopamine D3 receptors. Similarly, if you're going to use a drug with an anticholinergic effect, you should not really use the cholinergic subtype in your group. And secondly, it helps us personalize treatment via dashboard-based method. So these are all newer development in the management, clinical trial, and our understanding of non-motor symptoms of Parkinson's.